2017, the child was switched one drug, which is an nevirapine, was switched to Alluvia after the high viral load. Next slide. On physical examination, the child looks small for his age. The weight 21, which drops 7 kgs from the previous visit. Then height 113. The BMI for age is -3 SD, which is severely malnourished. Temperature 36, pulse 88, respirations 24, BP 107/84. The CD4 results were 644. That was before the child started ART. Then 21st September 2017, the viral load was 127, 432 copies per mil. Then September, 144, 745 copies per mil. Then we collected genotype in August and we received the results in October. And the results came as follows. The child has NRTI mutations and high-level resistance to abacavir, emtricitabine, lamivudine. Then also NNRTI mutations, which are resistant to efavirenz, etravirine, and nevirapine. Then has no PI and INSTI mutations. And then has a few other minor mutations which are listed below, but is susceptible to OPIs, including zidovudine, stavudine, and tenofovir. So the scoring for the mutations for NNRTIs, for efavirenz, total of 40, etravirine 30, nevirapine 75, and rilpivirine 45. So our question is, what is a recommended alternative regimen to switch to, considering that there is multiple drug resistance according to the recent genotype results?
Alida, thank you very much. Well done for that case. I know I saw a genotype come up and I sort of shivered. Can we have the spokes comment in case they need any clarifications from Alida on the case before I move on to the hub comments? Any clarifications from the spokes? Any questions that we need Alida to clarify? We have a question. Chatonda, please read it out.
Okay. This is from Pom Sanzia Zulu. Just a note for the TB HIV co-infected that sometimes you may have only AZT3TC or APC3TC. Consult if those are the only options.
Okay. I guess that's a comment, isn't it? Okay, so it's a comment on the if you have TB co-infection, that you may only have the AZT3TC or ABC3TC. Any clarifications for Alida?
Maybe I can ask. Yes. Okay, I just wanted to ask, was there an overlap between the TB and HIV treatment?
Okay. Makando, are you able to show the slide where she showed the ART transitioning from 2017-2018? So that we clarify if there was an overlap. I believe that's slide 3, the third slide. The one before, yes, that one. I think the question from Dr. Okaya for you, Alida, was there any overlap between the ART and the treatment, the TB treatment?
The ART was only started after the TB treatment had finished, because this child started TB treatment sometime in September in 2012. And then the ART was only started in 2013.
Okay, that's fine.
Okay, so the patient was only on the nevirapine, isn't it? When they were on ATT. Remember, he was on the prophylaxis, but we didn't start full ART until they completed the ATT. Is that right, Alida?
Yes.
Okay, thank you.
But still, there was an overlap between the nevirapine and the ATT. It seems to be, that's why I was asking about nevirapine and rifampicin. The levels of nevirapine are very low when you combine it with rifampicin, so it's as if you didn't give any nevirapine anyway.
Livingston, please go ahead with the comment or your question.
Okay, so Livingstone's question is, why was the child not switched to AZT initially?
So, Alida, the question is, Makando, let's put up the slide with the drugs. Why was the patient not switched to AZT initially? Why did we move from Abacavir 3TC, nevirapine, to Abacavir 3TC, lopinivir? Why did we just essentially do a substitution? We replaced nevirapine with lopinivir. Is there any reason why this happened, Alida? Do you know? I know that you just met the patient, you may not know, but...
I'm not sure why the person who saw the client didn't switch, because I just met this patient this year, so I wouldn't really know the answer to that question.
I think it's an important lesson for us to learn that if you are suspecting, if you are changing treatment and you are changing because of toxicity or there's a problem with tolerance or something, then you can substitute one drug. If it's nevirapine and you want to change because of skin rash or some other side effect, then you switch to the lopinivir. But in this case, there was a change made. It wasn't, when you are doing a switch because of failure, you don't change just one drug. You want to change, put 2 new drugs, not just the way you've just substituted nevirapine with lopinivir. Having said that, I even wanted to ask, how come you use nevirapine for prophylaxis and then you still went ahead and used nevirapine for treatment instead of the lopinivir? I'm not sure.
I think, as Alida mentioned, I think she was not the primary person, but I think what Dr. Okaya is expressing concern is we used the nevirapine in the prophylaxis and we went ahead and still used it in the full treatment for ART. I assume that's why we recommend lopinivir as that. Do we have any questions from the hub? Yes, Dr. Boyd.
So I have a question about the prophylaxis that this child was put on, single dose nevirapine. Is there a reason why that was done? Is this a low risk, high risk child, or because this would not have been appropriate for high risk?
At some point,
I missed it.
Sorry, Alida, I don't know if you will be able to answer this. The question is why we used only nevirapine single dose as prophylaxis. But I believe at that time we were not using the AZT3TC nevirapine. At that time, this was the standard practice in Zambia. So I think that's why they followed this regime. I don't know, Dr. Okaya.
Yeah, I think that's true. We only changed this in around 2016, in the 2016 guidelines. So
yeah, so the triple therapy only started in 2016. So this was what was there then. Any questions from the hub before I summarize the case? Yes, Duncan?
I missed the date of diagnosis for HIV. When did they get the positive results?
Alida, the question from Duncan is, when was the HIV diagnosis made? Makando, please go back to your first slide. Alida, are you able to answer that question, when we made the HIV diagnosis? Thank you, Makando.
Yes, the HIV diagnosis by DNA PCR was done on the 22nd of September 2013.
So when the child was 1 year? when he was 1 year, isn't it?
Yes.
Yes, it was a late diagnosis. Though he was on nevirapine prophylaxis because the child was exposed from the mom, the PMTCT.
Yeah.
Any other clarifications from Alida?
Even then,
How long was the prophylaxis?
The prophylaxis 1 year, 7 months. And the child was diagnosed at 1 year.
Yeah, it looks like the child had a very long nevirapine prophylaxis. Yeah, I was wondering why as well. He went on and on with that.
Okay. So I think there's concern that the nevirapine prophylaxis was prolonged. I'm not sure if people were waiting for the TB treatment to finish, as was earlier said. But as I mentioned, Alida just came across the patient very recently. That's why she got concerned and brought the case. Are there any questions from the hub?
Yes, I just had a comment, not necessarily a question on this case, but on the comment that Dr. Zulu made. The challenge we have in treating children below 3 months who are co-infected with TB is that for us to give the triple nukes is very difficult because both abacavir and zidovudine are co-formulated as a fixed dose with lamivudine. So for us to give that, it means we give the AZT 3TC dispersible tablet and then the abacavir adult tablet on its own. And it means having to sort of crush it and then come up with the correct dosage. I think that's what he was referring to.
So it's quite difficult.
Very impractical, yes.
Impractical.
Of course, not that many would have in that
category.
The few that we have.
Okay, do you have any questions from the hub? I'll summarize the case again, and Alida, please let me know if I make a mistake. So we have a 6-year-old, 7-month boy that had a positive HIV test at 1 year old, confirmed by PCR, was put on nevirapine prophylaxis from birth as mother was exposed to AZT and nevirapine while she was pregnant with him. In 2017, was observed to have a high viral load while on abacavir, lamivudine, nevirapine, which he started after completing ATT. He took the ATT with an overlap with nevirapine. So upon seeing this high viral load, a substitution was made where nevirapine was replaced with lopinivir, abacavir, lamivudine were continued. Of note in the physical exam is that the child has a BMI for age of only 11, I believe severe acute malnutrition, actually, when you do the calculation. So Alida is concerned because they've done a viral load here now in 2018, and this is actually very high. They went ahead and did the genotype in August. The genotype had mutations, the L74V, I won't go into that, had some major mutations, NRTI, some major NNRTI mutations. There were no PI mutations. The interpretation essentially was there's high level resistance to lamivudine, amitriptyline, and abacavir. There is some intermediate resistance to efavirenz, etravirine, and nevirapine. From the genotype, the child should be susceptible to lopinivir, tenofovir, atazanavir, darunavir, and all the PIs, essentially. So her question is, what regime should we change this child to? Doug, do you want to say a comment on this?
Hi, thank you, Sambo. I think Rokaya and some of the other folks have brought up some important issues in this case, but I think particularly in the interest of time we need to cut to the chase. What's going on with this child? It could be kind of summarized in about 4 or 5 words. And let me try throwing this out to the audience. There's something that just does not make any sense in this case. What is that? And then how do we make sense of it? And certain people are not allowed to answer the question.
I agree, Doug. So Doug's question is, when you put this case together, can any of our spokes or people in the hub comment on what's not making sense with the data we have so far? I know we have Chilenge, we have Livingstone, Petauke, Nyimba. please feel free to comment if you see that something is not right with this case, anything that appears odd from the physical and the results that we have.
After this box, I can speak. Go ahead.
Francis, go ahead.
Yeah. Okay. Yeah. So, first of all, I think it would be important for us to realize that we have to pick what the issues are with this child. So, clinically and on physical examination, this is a child who is not doing well and has got malnutrition, as we have been taught. So, basically, and with the underlying of HIV, then we know that he's not doing well clinically. Secondly, there's viremia, which is high viral load. But when we look at the mutations that are present, we find that one drug which the patient is on is still efficacious in terms of PI. There are no mutations to PIs, and the child is already on PIs, isn't it, for some time. Then the other issue, of course, some of the issues are in the past, which was the prolonged prophylaxis, and then the TB, and why the first ART treatment was not the correct regime. Now, if we have to focus at what we have, we'll find that it's not tying up where the child has got high viremia, and then the PIs are still working. So we have to actually question, is this child really adherent? Because just a PI itself can at least suppress the viral load to some extent. So if there are no PI mutations and there's still a high viral load, we have to look at the issues of adherence. If the issues of adherence are addressed, as we have been taught in history that the mother said the child is adherent, then we have to look at the gut integrity, especially that this child has got malnutrition, of which they are bound to have malabsorption syndromes. And is it due to minor dosage exposure due to that with the PIs? So I think these are some of the issues that we need to look at before we say, can we develop a certain regime that is going to work for this child? Because we have to interrogate why this child is not improving.
Thank you very much, Francis. Dr. Solomon, would you?
Yes, that was essentially the point I wanted to make, because we had several studies that had monotherapy with PIs, and they did very well. But again, coming to the fact that even though the child has been on a PI, you know that the PI generally have a high genetic barrier to mutation. So it's possible to be on a PI and yet not pick up a PI mutation. Nonetheless, there should have been some minor mutations to show that this child has been on a PI at least. And the fact that the mommy said that the child has been very adherent and yet on a PI, and then there was no viral suppression, I still am suspicious of the fact of whether, again, we've had issues like this even in my country, where because there was no lopinavir, ritonavir pellets, this child started taking it at 1 year, 7 months, or maybe it was, I'm not quite sure, okay. So maybe it was the crushed type of lopinavir that was given, which eventually is not as effective. So there are lots of issues that we need to interrogate for this particular patient. Now, but if the patient was given the right lopinavir and still not suppressed, this is a candidate that we need a very thorough investigation to be sure that the patient is taking the drug at all, or maybe the malabsorption syndrome is what we're dealing with. Because there is no way you'll be on a PI and the drug is effective and there are no resistance to it and it's not suppressing. So there's still some suspicion with this case.
Alida, are you still there?
But I wanted to make that point that if we are thinking about moving forward, we will probably, this is a patient that will benefit from going back to good old zidovudine. If I'm the one taking care of this patient, I will still throw in lamivudine in there because the M184V mutation strengthens zidovudine. So if we put the lamivudine, zidovudine, and then the lopinavir, ritonavir, and ensure that this patient is adherent to this drug, and there is no malabsorption there, the patient is well tolerant to the drug, the patient will do well on his lopinavir, lamivudine. That's my submission.
Hi, Alida. Did you hear Dr. Solomon's submission?
Yes.
Yes, there are people are worried that the child is not showing any PI mutations, so there is doubtful exposure. I don't know, Doug, you asked that question. Do you want to zero in on that?
Yeah, I think we have nicely sort of zeroed right in here. And I think for everybody, it really, really is worth emphasizing that the viral load history, the genotype history, and the medication history, you look at that information, one of those pieces of information has to be wrong. Either the viral load's wrong, the genotype's wrong, or the medication history's wrong. And in this case, I'd be almost certain that it is the medication history that it's wrong. The child simply is not on Kaletra right now. One of the questions I had was, what is the formulation of Kaletra that the child is taking? And I think particularly if it's the liquid formulation, we can understand why the child might not be taking Kaletra. But to back up on a couple of things, first of all, what the genotype shows is exactly what you'd expect from a child who's on abacavir, lamivudine, and nevirapine and failing therapy. He's acquired exactly the mutations that you'd expect, and it's like we didn't need the genotype to tell us what the genotype says. He has the L74V, which is a characteristic abacavir mutation, the 184, of course, the 3TC mutation, and the 181 and the 108, the nevirapine mutations. And I should say, with 181, you get a Favrins resistance score of 30. With 108, it goes up to 40. That was shown there. Even with the 181 alone and a mutation score of 30, the bottom line is Favrins is not certain, but likely to fail, particularly in a high viral load patient like this. So we have abacavir, lamivudine, and nevirapine and a Favrins resistance. So the child had a viral load of, I think it's about 140,000, starts on Kaletra. A year later, the child has a viral load which is essentially the same. There's no difference between 125 and 140,000. There's no difference at all. Now, certainly, I have seen children in Zambia and elsewhere in a year's time march through lopinavir and develop complete resistance to lopinavir, which you can do in 3 mutations. As was pointed out, the switch that was made back a year ago, the nevirapine was dropped and the lopinavir was put in, but the abacavir was kept, and zidovudine would be a very effective drug in this case. Both the L74 and the 184 actually increase the sensitivity to zidovudine, and one of the discussants mentioned that's on paper right now, zidovudine, lamivudine, and lopinavir would seem to be the right treatment. But be that as it may, the child supposedly got put on lopinavir and then had no viral load suppression, and despite the fact that there's no lopinavir mutations now, and as is pointed out, we don't even see a single protease inhibitor mutation, and it would take about 3 of them to actually completely blow away the lopinavir. So we have a situation where we have a child who simply is not taking his lopinavir. If you've ever tasted lopinavir, you will understand this. And if you haven't, I would encourage you to put a drop on your tongue. 20 minutes later, you'll still be tasting it. It's pretty obnoxious. So I must say, we see this, and this was brought up, we see this over and over. Where there's not adherence, the history and what is happening in reality are different. And so I think our first issue is, how do we get over that hump? How do we be able to have a discussion about adherence in this case? We know that the child's not getting his lopinavir. The mom just said the child's getting all of his medications. So one of the questions I had actually is, what's mom's viral load? If mom's fully suppressed, that's a good idea. That's great. If mom is not on ART or something, it would again add something that would make us sort of wonder, wait a minute, what's mom's thinking about this whole HIV thing? Okay. My guess is mom's probably doing fine, but I think it's worth asking, because it might give us a hint about what her thoughts are, and is there some self-stigmatization and so on that might be going on here, and so on, that she is reluctant to use antiretrovirals in herself or her child. But I think, the most likely thing is that the child just simply went nuts when the mom tried to give the child lopinavir, and that battle ended. Sometimes also what happens is those battles are rather obvious, and if the mom is trying to hide the fact that the child has HIV, which means the fact that she has HIV, trying to hide that from other members in the household, she might not have pursued giving the lopinavir and pursued this battle, because then people start asking questions. Why are you giving him this medication? And, the subterfuges about, it's the vitamins or the antibiotics or, whatever, become more difficult. Certainly I've seen cases where just for that reason, parents stop giving medication because, there's somebody else in the household, the father, the grandparents, who don't know the diagnosis. They're trying to hide it, and they when a child's making a fuss, that makes that difficult. The other question that I had was, what formulation of lopinavir? Is the child indeed taking the liquid? Actually, when I took the numbers on this child and look at the dose, the child's actually the right size for one adult tablet. And sometimes it's amazing what a 6-year-old will swallow. It certainly is amazing the kinds of things we find in their stomachs and are caught in their esophagus, when they swallow all kinds of junk. So a 6-year-old actually is quite capable of swallowing a Kaletra tablet. They're pretty big, and some of them will have trouble with it, but a lot of 6-year-olds could just swallow down a lopinavir tablet. And it may be the solution to this is, just run over to the pharmacy, have them hand you a tablet, and give the child a cup of water and the tablet and say, hey, can you swallow this? And the kid may just take it right down. And it's like, okay. And you just say, well, let's switch to the tablets. I think it'll be easier for him to take. And then see what happens, with the viral load a month later. It should vanish. And as I say, we do want to get the child onto zidovudine also. So that's basically the situation. So I think it really, I would have to sort of put this in the hands of whoever knows this family the best. And how do we broach the issue of the child not taking the medication? Remember, as soon as we do that, when we say he's not getting the medicine, we're also saying you're lying to us. And, people don't like to be accused of lying, particularly about the health and safety of their child. So I think it takes a very sensitive approach from somebody who really knows the family well. And as I say, looking at some of the other things around this situation, what's her attitude towards her own diagnosis, other people in the family. And for example, we don't even know who's actually giving the medication. Maybe mom is not the one who gives the medication. Maybe it's the aunt or the grandmom or the uncle or something like that, who doesn't even know the diagnosis and doesn't like to fight with the child about this, and so just pours the medicine out or something like that. So let's find out who gives the medicine, what is their attitude towards the disease, who are the other adults in the household, do they know the diagnosis and the mom and the child? Are they supportive and so on? And at a certain point, you have to just say, hey, I think the liquid's a problem here. He may be spitting it out. And there are plenty of children who will put it in their mouth and then walk out the door and then spit the medication out. I had a case similar to this where actually he was an adolescent. We had a DOT. We were doing DOT, ART. The DOT worker goes to the house, gives the child the medication. Then child then comes to my clinic. I draw a level. This was Adherence. And the level's 0, 2 hours after the DOT worker said, I gave him the medication. Then I asked the kid, I said, there's no Adherence in your blood. You didn't take the pill. He says, yeah, you're right. I didn't take the pill. I just put it in my cheek. And then when he left, I spit it out. Okay. So American kids do this. Zambian kids do this. The upshot of it is our viral load and our genotype have become a very expensive adherence history here. And we have to go into the really hardest part of HIV medicine. And that's working with families and children to cut through some of these adherence problems. Now, it may come down to we're just not going to get Kaletra into the child. What would be our alternative? The upshot of it is, we could try to do some things with dolutegravir or something like that. Although, do you have I should have it here, your formulary. You have the dolutegravir, I think you have only combined with tenofovir. And as has been pointed out, we never want to overdose tenofovir. The raltegravir, you can put the 2 pills side by side and decide, zidovudine, lamivudine, and raltegravir work fine in this child. And without having it right in front of me, my sort of recollection is that the raltegravir pill is a little smaller than the Kaletra pill, and that would work perfectly fine too.
Thanks, Doug. Thanks a lot, Doug. Alida, I think you brought up the issue of the HB. I know you submitted that the HB was 14, but I think this morning you said the HB was 8. Would you like to clarify that?
Yes, the one after the 14 was 8. It's the 8 grams per deciliter is a more recent one than the 14.
Okay, thank you, because I'm looking
at the recommendation. Have a hemoglobin of 8 point whatever.
Sorry, say that again, Doug. We didn't get you.
Why does the child have a hemoglobin of 8 whatever it is now?
8.
Why?
Nutrition.
It's a good question. Obviously, their TB, though. Of course, there's the issue that the child is severely malnourished. We also need to know why the child is severely malnourished. Actually, severe acute malnutrition when we did the calculation with the pediatrician this morning. But just hold that on. Dr. Mlenga, you wanted to say something?
Yeah. I wanted to agree that I think this patient is not taking the PI. If you look at the mutation profile, the 74 points to ABC, the 115 points to ABC, and purely those are ABC related, as a 184 for the 3TC, then a 101 and 181, which again you usually see with NVP much more compared to the Adherence. Then for more than a year, not suppressed still. Of course, if it's not working, the PI, if it's not working, I wouldn't expect that the patient, this kid would be suppressed, but we should be seeing some resistance. So I think they are not taking the PI. I think forcing this child to go and take the PIs would be a bit difficult. We need to look at other drugs which the kid has to be put on. TDF was, Doug mentioned TDF. We have the lower formulations of TDF. We have them. We have them.
We don't have them at our
150, yes.
Please speak up.
We have the 150 at MSL. Then we have the 3TC, of course, available, which may not do much work here, but maybe for hypersensitivity.
I think from the clinic point of view, they seem to think adults are children are mini adults, so they just give them the convenient one tablet adult, because they'd rather, instead of giving them the separate TDF 150, 3TC, and Adherence.
Yeah.
So instead of separating them, they find it convenient to just give one adult tablet or half adult tablet. That's
So,
the issue is.
so I think for this child, you need to calculate really what you need if you're going to use TDF, because even those TDF which we have in MSL, we're even planning to use it in adults so that it doesn't go to waste, because in children it's not being utilized. Then DTG, FDA DTG from 6 years has been approved. For the Europeans, from 15 kg since 2017. WHO now has also recommended for use of DTG, so maybe if you look at weight-based formulations, it's one drug which you can also consider. Maybe it may be, and with this high viral load, it may be a drug to consider looking at your pediatricians when you calculate, would it fit in there? Of course, we have the standalone DTG, which is not combined with the TGF and the 3TC. Then consider raltegravir, of course, the possibility of raltegravir, which we have, formulations for children. So my thinking is you need to run away from the PI.
Okay, so
It's more about access and availability.
Those drugs are available. The ones I've mentioned are available.
Side.
Yes. As long as there's an ATC nearby, and drugs can be sent to wherever the patient is.
Alida, are you still with us?
Yes, we're still here.
Okay, Doug, did you want to say something?
Yeah, my recent information is that there's a TDF 150 available at the PCOE. That's what the PCOE pharmacist tells me. So it is an important point. Sometimes people think that you can't use a drug or whatever because it's not happen to be sitting on the shelf in your hospital. But all you really need to do is ask for it, and it will appear. And I'd have to sort of do the calculations, but my hunch would be a TDF 150 would fit the child. And with respect to dolutegravir, nobody ever died of a dolutegravir overdose, that's for sure. We're talking about an extremely safe group of drugs. The dose is about, is approved for larger children in the United States. We actually have 10 and 35 milligram tablets available in the United States. This child at a milligram per kilogram, we probably need to think about the child's prior weight is what the real weight is, more like about 28. But you probably take about a half a dolutegravir tablet. But as I say, I don't worry about overdosing somebody on dolutegravir. We double the dose of dolutegravir if we're giving it. We double it. We give it twice a day. It's labeled for use given twice a day if you're overcoming partial integrase inhibitor resistance. It's also given twice a day if it's given with rifampicin. So I wouldn't worry too much about giving this child an adult dolutegravir tablet. You can try splitting it in two or something, but I think in terms of, as I said, I'd kind of have to line up the options, and maybe line up the options in front of the child. There's the raltegravir, there's the Calitra tablet, and even just grab the Calitra tablet and take it. Okay, problem solved. The 150 tenofovir is probably not too big. The only issue then is you have to come up with I guess the question is, do we have a lamivudine that we could give the child? And I'd have to look. We have 150 lamivudine standalone tablets are available also. Or we can actually, what we could do is we could take the tenofovir 3TC tablet and split it in two, and then give them probably close to the right dose. You'd be a little low on the lamivudine, be close to the right dose. But no, we never want to overdose tenofovir. That's the one drug we've talked about here. And even going back to the zidovudine, the cause is probably the AIDS is the cause of the anemia. And you put them on zidovudine, lamivudine, and Calitra, his hemoglobin will probably go up. And one final thing, in terms of the male absorption, this comes up a lot. I must say, I've only once in my career seen like 8 gazillion children with HIV, seen a case where actually there was malabsorption of antiretrovirals. It was really significant. And this is somebody who had end-stage heart failure and severe gut edema, anasarca, and didn't absorb drugs or food or anything. So, the child's not taking the medication, and we got to figure out how to get over this psychosocial hump here. And I think others have brought up a lot of the different options that might be available, and I think it's just kind of a matter of working with them.
Thank you very much, Doug. Alida, are you still there? Before I wind up, I just wanted to check with you if those recommendations are okay with you. Would you like me to summarize them?
Yes, I think you can summarize them for us.
Okay. In view of the fact that there's an HB of 8, we need to make sure we look for possible etiologies of this low HB. Obviously, it could be just because the HIV is uncontrolled. So controlling the HIV is paramount, and we note that severe acute malnutrition is present. We need to manage for that as well. But that says, in terms of the ARVs, we have a few options for you. We could use TDF 3TC with raltegravir. I know we have the pediatric formulation available. So your option is TDF 3TC raltegravir. Your other option is AZT 3TC raltegravir, but closely monitor the hemoglobin, likely to peak rather than drop if it's because of the HIV. But I think what is coming out here is that the child, for some reason, is not taking lopinivir. I know Doug always says lopinivir is extremely bitter, it's unpleasant, because the child is taking some drugs, abacavir 3TC, but not taking the lopinivir. So we need to also explore the psychosocial issues. Who is giving this child the drugs? Do they know how to measure? Are they, maybe sometimes the caregiver is too old or too young? So we need to maybe go further and do some psychosocial counseling and see what's going on with this child. Why is the child not getting the lopinivir? It may be something straightforward like, oh, he takes the tablets and then spits out the liquid. So we need to find out that. However, the recommendations are you use raltegravir because we have the loose one, the pediatric one available, I know. With 3TC and AZT and TDF, this should work as long as we also take care of the things that are happening in the background, things like the malnutrition and the anemia. And also, Doug brought up something very interesting about the mother. What's happening to the mother? What's her ART? What's her viral load? Is she suppressed? Who is she with? So if the mother is suppressed, you get a good idea of how she's managing to give this child the ART. So you may also want to check for siblings. I noticed that our form, there was nothing on what's happening to the other children. We also need to follow up on this woman's other children. Are they HIV positive or not? If she has a partner, we also need to test them. Alida, is that summary okay, or is it too much as well?
It's fine. We've taken note of the suggestions.
Okay, thank you. Well done. I think we've even run out of time as usual, but thank you very, very much, Alida. You are sending in very big, complex cases, but thank you. We are all learning so much from it. I know I am. Have a good day and all the best with the patient. We'll be in touch and assist you follow up this patient. Thank you. And it's a wrap.
TG they can give us.
Do we have?
Yes.
Oh,
Pediatric one.
Do we have? No.
Great.
okay, Doug, would you like to hang on for a bit?
Yeah, I'm fine.
Hi, Doug. Are you still there?
Yeah, Samba, what is it?
Yeah. Thank you very much. So we have a bit of an issue. We may go with the DTG because Lloyd said it's available. I didn't know it was. It's not in our guideline. Okay. Hi, Doug.
Yeah.
Hi. I'm going to write you an email on our options before I send them to her, especially the dolutegravir. I need to get the status for the pediatric dolutegravir, then I'll tell you what we have, then we can make recommendations for this lady.
Okay, that would be great, because actually, as you know, tenofovir, azadovidine, lamivudine, and raltegravir would probably work in this child, but we have to be nervous about adherence, and with raltegravir, we could blow through the raltegravir, and that'll compromise dolutegravir in the future. So if we could go straight to dolutegravir, that would be great.
Okay, let me see if we have it, then we'll use dolutegravir. Thank you very much, Doug. I'll write to you. Thank you.
Yeah, I think written recommendations would really be good for the team, because this is complicated.
Yeah, it is complicated, isn't it?
Yeah, thank you.
Okay, bye. Thanks, Doug.
Bye.
Lastina, hi. Thank you for saving the day by uploading the slides and everything. Thank you so much.
We are a team.
Thank you.
That's why we are working as a team, Sombo.
Okay, Lastina, do you think that we should email you guys the slides as well then in future? Because I just sent you.